we are thrilled to have Dr. Jill Rathis with us today, and I'm going to turn it over to her to get started.
That introduction, Melanie. And thank you also to the staff at BTech who to do this webinar and who got me set up here. I wish I could see all of you, but I'll do the best I can just talking into my computer screen. Okay, I mentioned my conflicts of interest, and so we have the couple of recent books, DBT Skills Manual for Adolescents and DBT with Suicidal Adolescents, Our Conflicts, as well as my being a trainer with behavioral tech, and as well as my role as co-director of Cognitive Behavioral Associates in Great Neck, New York. In the 1990s, Alan Miller and I began adapting DBT as the first comprehensive treatment for multi-problem adolescents at high risk for suicidal and self-injurious behavior, and developed DBT for adolescents to address the unique challenges that arise during treatment with multi-problem adolescents and their families. And I'll be discussing the evolution of DBTA. I had an overview of the adaptations made to standard DBT to address needs of adolescents and their families. I'll be discussing treatment modalities, including multifamily skills group and family therapy sessions, the adolescent and family secondary treatment targets, the list DBT skills for adolescents and caregivers, and finally concluding with suggestions for additional training and self-study in DBT for adolescents. Objectives of the webinar are to describe the evolution of DBTA, to understand changes to treatment modalities in DBTA and additions to DBT secondary treatment targets, and view recent updates to DBT skills for adolescents and their caregivers. So I'll start with an evolution of DBT for adolescents. 1990s, actually my first job out of graduate school was a position at Montefiore Medical Center's Adolescent Depression and Suicide Program in the Bronx, New York. And I was hired after internship to be the research coordinator of the clinic, and around the same time, Alec Miller was brought in to direct the program. We've been co-interns together, and so we started this journey together way back then. And the population we were working with was mostly suicide attempters, people with self-injurious behaviors or suicidal ideation, people with kids with multiple problems, school problems, family problems, substance abuse, trauma, and emotion dysregulation, many with BPD or features of BPD. And the task of finding effective ways to help these kids. No empirically validated treatments for these adolescents existed. The rated treatments focused on depression and excluded suicidal adolescents or excluded those with multiple diagnoses, or were emergency room-based short-term crisis interventions for suicide attempters, but without follow-up or comprehensive care. So we learned about this new treatment, DBT, and we found out that DBT was an evidence-based treatment for suicidal patients diagnosed with borderline personality disorder. That DBT was designed for the chronic and severe multi-diagnostic, difficult to treat patients with both Axis 1 and Axis 2 disorders. And we thought this might be just what we need for these multi-problem kids in the Bronx. There was only one randomized controlled trial published. It was Linehan et al.'s 1991 RCT. Since then, of course, well over a dozen RCTs have shown the effectiveness of DBT with adults. But at the time, the 91 study was promising enough for us, showing that it was effective. In particular, that DBT was superior to comparison treatment in reducing suicide attempts and self-injury, premature dropout, inpatient and emergency room admissions and days, use, depression, hopelessness, and anger, and impulsiveness, while increasing global adjustment and social adjustment. And more recent studies have shown very similar outcomes. We read the books, and we got over to Seattle and got intensively trained by Marcia. In the 90s, we began piloting DBT within this inner-city outpatient clinic with teens and parents. We used the original Linehan Skills Manual, and basically went through every skill with the families and got participant feedback, and we were first learning them and applying them ourselves. One of the things we found right at the beginning was that many people had difficulty reading those handouts and comprehending the material, and that was partly due to reading levels and partly due to the fact that many of these were immigrant families that English as a second language. We saw right away that we needed to simplify, and we started rewriting the handouts to keep all the essential points but make them a little bit simpler. And also saw, of course, that the developmental needs were different because we were working with kids, not adults. And so we found that we needed stories and examples and exercises that applied to these kids. And we also saw that the family context needed to be addressed and that the families needed to be engaged. So we modified the treatment only where necessary, based on characteristics inherent to adolescence. We use DBT, but